Dear audience, welcome. I'm Mariangela Pellegrini. I'm the Educational and Patient Program Manager for the ERN-EuroBloodNet, so the European Reference Network for Rare Hematological Disease. And it's my great pleasure to welcome all of you today at this cycle of webinar targeting patients and their family, people living with sickle cell disease. And this is a program named ERN-EuroBloodNet Topical Focus on sickle cell disease for patients and their family. And indeed, it's 11, it consists of 11 webinars. And all the topics of those webinars have been selected by the patients community and people living with sickle cell disease, caregivers. So we are going to talk about polyuria and énurésie, kidney damages in sickle cell disease. With us, we have the honor to assist to Professor David Rees lecture, who is a pediatric hematologist at King's College London and King's College Hospital, with of course an expertise and interest in red blood cell disorder like sickle cell disease, thalassemia, and other inherited red cell disorders. So please, Professor Rees, the floor is yours. Thank you very much.
Yeah, thank you for asking me to talk about this. I'm a pediatric hematologist, and this énurésie, which is the main topic, is important in children, but very, very important for parents and also for some adult patients. Let me just make the slides move. So these are my list of various committees and boards I'm on for commercial companies, none of which really influence what I say in this talk. So just talking a bit of background about kidneys, which you probably already know, but kidneys have several jobs in the body. The main one is probably to filter blood and remove toxins and waste products, and they produce urine, which is how these products are got rid of. The kidneys also make hormones which control blood pressure and also make hormones which drive red blood cell production, but I'm not going to say more about that. This is a picture showing with the kidneys that, as you know, there are two kidneys quite high up in the body under the ribs, so you can't normally feel them unless they're very enlarged. And the kidneys have two tubes which go down into the bladder, this thing at the bottom, and then the bladder, then the urine passes out of the bladder through the urethra. Normally the blood goes into the kidneys through a big artery, which then branches into lots of smaller arteries. These smaller arteries go to lots of tiny little filters, which are called, each one is called a glomerulus, and the filter sort of separates the cells and protein from the plasma, and the plasma goes through tubes in the middle part of the kidney, and all the waste product is removed into urine, and the plasma is left and then returned to the blood. So clean plasma returns to the blood, and then the urine passes to the bladder through the ureters, which I mentioned. And this is again a picture of the one kidney cut in half. I mean, it doesn't show you much other than there are lots of blood vessels. The kidney has a very high blood supply. Obviously, it's nearly a third of the blood goes through the kidneys at any one time. And this is a different version of the same sort of picture showing the arterial blood, the dirty blood going in, clean blood comes out, and the urine comes out. And this is a sort of close-up where the blood goes into this little network of blood vessels, the glomerulus, and it filters through to produce the urine, and then the urine tubes wrap around the blood vessels, and more waste products comes out of the blood into the plasma, and the urine into the urine, rather, the urine goes out, the blood goes back into the circulation without all the waste products in it. It's very clever. And kidneys are often damaged in sickle cell disease in any number of different ways, which I'll mention briefly. In the kidneys, there's several things about the kidneys that make them particularly prone to cause sickling. There are low oxygen levels in the middle of the kidney because it's a very active sort of organ and the oxygen is used up. It's also quite acidic. Part of its role is to to remove acid from, to deal with acid and sort of balance, and to remove acid and from the blood into the plasma, meaning that the acidic environment tends to cause sickling. And there's also a very high concentration of some chemicals, which tends to make the red cells dehydrated. And that red cell dehydration, where the red cells lose water, is one thing that tends to promote sickling. Then the rigid cells, which occur in the, the sickle cells, which occur in the kidneys, damage blood vessels in the kidneys, and also damage the kidney themselves, sort of reduce the amount of kidney tissue that people with sickle cell disease have. There's also lots of other abnormal things going on if you have sickle cell disease, including in anemia, inflammation, abnormal blood clotting, and these may all contribute to kidney damage. And then some drugs may damage kidneys, the most notable ones being some painkillers, so-called non-steroidal anti-inflammatory drugs like ibuprofen, which some people, if you have a lot of pain, end up taking quite a lot of. So kidney failure these are different, there's a range of different problems that can happen to the kidney. I'm only really talking about one of them, with the problem related to too much urine, but just to briefly go through other problems. Kidney failure occurs in quite a lot of adults as they get older, and it's not so often a problem in younger people and children, but it can, in about 30% of adults, develop some degree of kidney problem. And this is mostly just to do with infarcting, with scarring of the kidneys that is caused by sickling happening over the years. Blood in the urine can occur, so-called hematuria, where the urine looks very red. And this is usually because the kidneys have been damaged by sickling, and if the bit that is damaged is close to the urine tubes, then that means that they bleed into the urine. It kind of looks quite dramatic and it's quite a frightening symptom, but in general is not serious, at least in the sense that it usually stops without the need for treatment, although people are often monitored in hospital. Very occasionally, if there's lots of blood, you can get blood clots forming, and that can sometimes block the passage of urine. One problem is that kidneys can become leaky. The main aim of the kidneys is that one of the important things is that they filter out the waste products, but they keep all the things the body needs, so that isn't lost in the urine. One of the important things are various proteins, and the main protein is albumin. And in some cases, then if the kidneys become leaky, so you start losing things that you should keep in the body, particularly albumin, and the protein levels in the plasma can go down, and that can cause a range of problems. And in fact, when you test people carefully, quite a lot of children have small amounts of albumin present in the urine, small amounts of protein, if you test it carefully with chemicals or with dipsticks. And that can increase with age. And in about 20% of adults, that is a problem, where the protein levels get low because you're losing protein in the urine. And then there are other kidney problems. The one I'll talk about is that there's an increased urine production, really. So the volume of going through, and that occurs for several reasons. One, the amount of blood going through the kidneys is increased in sickle cell disease, partly because people are anemic, so the blood circulates more quickly. There's an increased volume of urine produced, which is called polyuria. And this tends to occur early on. It happens, unlike some sickle things, if you measure carefully, it happens pretty much in the first year of life. It doesn't cause any problems then, but compared to babies without sickle, babies with sickle produce more urine, and they filter blood much more quickly. It's not really known exactly why this occurs, certainly in very young children. It's possibly because the anemia itself means the blood flows more quickly, causing the high levels of blood urine production. And it may be sometimes because there's a decreased sensitivity to some of the hormones, which I'll talk a bit about, which helps control how much urine you make. But the bottom line is, in sickle cell disease, kidneys produce dilute urine, which contains lots of water. In the normal situation, if you don't have sickle cell disease, when you become dehydrated, the kidneys work to keep more water in the body because you sense that you need to not lose water. So the various filtering systems keep as much water as possible in the body and let as much waste as possible out. And in sickle cell disease, that ability to make concentrated urine is damaged and is impaired from quite an early age. And that's particularly important at night. When you go to sleep, normally the kidneys kind of shut down. You make a very small volume of concentrated urine. And again, in the same way, that's also impaired in sickle cell disease. And these problems occur partly because of the sickling that goes on in the kidneys, which damages them. And there's also a very specific problem with the hormone, which makes urine more concentrated. There's a hormone called vasopressin, or ADH, antidiuretic hormone, which the brain makes. And the brain senses when the urine, when the plasma, when your body's getting dehydrated, and it sends out this hormone to keep more water in. And in sickle cell disease, you still make the hormone normally, but the kidneys are less sensitive to it, so they can't respond in the same way. So in sickle cell disease, there's a larger volume of quite dilute urine produced, and that means that there's an increased risk of dehydration if you're not drinking enough. And there's also increased urine production at night. So that situation where you produce a large amount of urine is called polyuria, as I think I mentioned earlier. And that's not very well defined because people, obviously it's measuring someone's urine. It's not a very easy thing to do, but it's thought overall that if you produce more than 3 liters of urine per day as an adult, then that is abnormal. And there are many different causes apart from sickle cell disease, which is one. One is if you drink lots of water, you pass lots of urine. Drinking alcohol and caffeine, both of which are so-called diuretics, increase the urine output. Lots of medicines increase your urine output, including quite a lot of drugs which are used to treat heart failure, and they work by increasing the amount of urine that you produce. And diabetes also increases your urine output. And normally you can, as I say, you can alter how much urine you want to lose depending on how dehydrated you are. And when you get very dehydrated, that is when your kidneys reach their maximum urine concentration sort of ability. And in adults, normally the most concentrated you can make urine is 1200 milliosmoles per kilogram, which is the units which are used. And in sickle cell disease, then that is approximately half the normal. You can only make concentrated urine up to about half the amount of or even a third of the amount of an adult without sickle cell disease, which means it's difficult to keep water in situations where you need to keep water. Just by contrast, I mean, lots of animals live in the desert and they have very efficient kidneys that can keep almost all the urine in the body, almost all the water in the body. I mentioned the chinchilla there, which I think must live in a desert and makes incredibly concentrated urine. It's sort of 6 or 7 times more concentrated than strongest human urine. And if you've kept chinchillas or hamsters, then you'll know their urine is kind of horrible gloopy stuff due to the fact that they normally live in a desert and they're very, very good at keeping water inside their body. See, one way of judging the strength of your urine is using a urine color chart, and there are lots of these that are produced for all sorts of reasons. People are there's crudely, you can look at your urine color and decide whether you need to drink more water or not, and some people suggest people should do this. In sickle cell disease, it's much more complicated because the urine is often dark for other reasons. People with sickle cell disease are quite often jaundiced, and sometimes the jaundice gets worse if they're unwell. And the jaundice, the bilirubin, which causes the yellow color, also passes out in the urine. So the urine often looks quite dark, even though the urine may not be very strong. So it's much harder to judge, how hydrated you are by looking at your urine in sickle cell disease. If you see very dark urine, it could mean 2 things. It could mean you're very dehydrated, or it could mean you've got lots of bilirubin. You've got, for some reason, the level's gone up. So the consequences of polyuria in sickle cell disease are several, really. One is that there's an increased risk of dehydration, and that is particularly true in very hot weather. If you have, increased fluid loss with diarrhea and vomiting, or if you're not able to drink fluid easily, if for any reason you don't have access to water or other drinks. And also if you're in hospital, particularly say if you're in with a crisis with bad pain and you have lots of strong painkillers like opiates which make you sleepy, then it's very hard to wake up and drink enough. in normal situation, when you're, it's a normal temperature and you have as much water as you need, in general, that people with sickle cell disease don't get more dehydrated. So in a normal condition, you don't necessarily need to drink much more water with sickle cell disease. It's just in some situations where, when it gets hot, when you normally make more concentrated urine, people with sickle cell disease still lose more water. So it's more important to drink then. So the general advice that you should drink plenty if you've got sickle cell disease is true, and that's an important thing to do. But it's particularly true if you're in any of those situations, like it is very hot weather, or you've got diarrhea or vomiting. Dehydration is bad, and it's bad for everyone in that you lose the volume of your blood is reduced, and it tends to make things like organs like the kidneys work less well. In sickle cell disease, it's a particular problem because dehydration tends to increase the sickling that goes on. The red cells themselves get dehydrated, which concentrates the hemoglobin and tends to cause sickling. So getting dehydrated is recognized as one possible cause of getting acute painful episodes. And quite often patients can relate the development of pain due to a problem that develops. Sometimes it's not always quite so straightforward to know what's caused it. But certainly dehydration is one possible factor. The other important consequence is that there is increased amount of urine produced, particularly at night, which you'll come on to. So as I said, really normally the kidneys shut down at night and you don't make much urine during the night. But in sickle cell disease, from an early age, that's not the case. So in terms of drinking, as the same, people with sickle cell disease don't need more water inside their body than normal. The advice is they need, like everyone, they need to drink as much water to replace the water that they've lost. And there's not really much evidence on exactly how much water people with sickle cell disease should drink. In normal conditions where it's not too hot and you've got plenty of water and you haven't got diarrhea, then it's probably about the same as other adults, about 3 liters a day. But when fluid losses increase with hot weather or excessive sweating or diarrhea and vomiting, then people need to increase the amount of water they drink more than someone without sickle cell disease, because they're not able to keep water in the body in the normal way. People should avoid going long periods of time without drinking. So there's a tendency amongst everyone, sickle cell people and people, everyone, to drink water continuously, to constantly sip water, which is fine in a way. And I think that's fine if you want to do that with sickle cell. I think it's not absolutely necessary. I think people are designed to, you drink water 3 or 4 times a day in a large amount. You don't necessarily have to sip it continuously. But some people like to, and maybe there are some health advantages for that, although it's not really known. But in general, people with sickle in normal conditions should drink normal amounts, really, but need to be very careful if it's hot or if they're getting dehydrated. It's not very clear whether there's a benefit to drinking more fluids than you need. In general, if you drink too much fluid, you just produce some more dilute urine, you just wee it out. Some people believe that, you can flush out toxins and things like that by drinking too much water, but there's no real evidence for that. Sometimes people feel better if they drink more water, which is fine. It is potentially dangerous to drink too much water, in that the kidneys, in the same way they can keep water in, they can only cope with getting rid of too much water. And if you drink too much water, then you keep that water in your body, and that causes a whole different set of problems. The other issue is about intravenous fluids in sickle cell disease, that when people are unwell in hospital, having pain or other symptoms, they're often given intravenous fluids. Again, it can be a useful thing to do, particularly if someone's very sleepy or they've got vomiting and they can't drink. But it's also quite a dangerous thing to do. And although people have done this for years, we still don't really know how best to give intravenous fluids or how useful they are. It's important if a patient comes in and they're very dehydrated, if they're unable to drink or they've got significant diarrhea and vomiting, then giving IV fluids is important. In general, if those aren't the situations, it's better to give oral fluids, in that it's a more natural way to give fluids, and you don't tend to get people overloaded with fluid, you don't fill people up so much that it causes problems. The problems with intravenous fluids are that you have to put a drip in, so it damages the veins. And after many years, people start to run out of veins. And also, it's an unnatural thing to do. So it's much harder to balance the amount of fluid and electrolytes. So it's easy to give too little fluid or too much fluid, and to make the sodium and potassium too high or too low. So moving on to enuresis, which is probably the main symptom I wanted to talk about in this talk related to the kidneys. It's a very important symptom, which is kind of neglected and not talked about that much, and there's no easy answers to it. But enuresis, as I guess most people know, means involuntary urination, and there's several ways it occurs. There's nocturnal enuresis, which is mostly what I'll talk about, where people wet the bed at night. Then some people have daytime enuresis, where they have wetting during the day, often at night as well, but sometimes during the day. And people also talk about primary enuresis, which means children who've never learnt to be dry. So they've never stayed dry at night, for example, they've always wet the bed. Or secondary enuresis, where children were dry, they were sleeping through, but then they start to wet the bed at a later stage, which is a completely different sort of condition, which I'll mention briefly. Mostly what I'm talking about now is primary nocturnal enuresis, which is when children or young adults take a long time to get dry at night. Nocturnal enuresis, bedwetting, is quite common, and there's probably the most common definition of when it's significant is if after the age of 5 years, at least twice a week, people wet the bed, and that goes on for 3 months continuously. Although obviously there's variation in between that, and most people probably don't wet the bed at all, but some people wet the bed every night. In the general population, not in sickle cell disease, but also in people without sickle cell disease, it's fairly common. It tends to run in families, and it's much more common in boys than girls. And at the age of 5, about 7% of boys and 3% girls have enuresis, according to the definition at the top. Then at the age of 10, about 3% of men, 2% of women. Then over the age of 18, it's very uncommon in women, but about 1% of men still wet the bed at that age. And certain conditions increase it, including sickle cell disease, diabetes, constipation, obstructive breathing during night, and I'll run through some of these. So as I've said, really, nocturnal enuresis, bedwetting, is much more common in sickle cell disease. People have tried to look at it, but there's not very good data on it. But overall, then about 5-year-olds, about 30 or up to 50% of people still wet the bed with sickle cell disease. And at the age of 10, about 15 to 20%. At 15, it's about 10 to 15%. And about 5 to 10% of people with sickle cell disease still have a problem with enuresis when they're an adult. And I've mentioned some of the reasons, really. The reasons for the increased nocturnal enuresis, bedwetting and sickle cell disease, is mainly the higher urine output at night, that people just produce more wee during the night, so it's harder to deal with it. There's often, I'll come on to it, often there's a tendency to drink water. As I said, there's a tendency to feel you need to drink plenty of water, and sometimes people continue doing that during the night. There is some evidence that bladder may be more unstable. That means really that the bladder normally is like a balloon, and it blows up to a certain time and then contracts, and you can control that. But in some people, the bladder contracts unpredictably. It reaches a certain side and then contracts very suddenly, and it's much harder to control. And there's also a higher rate of having snoring and obstructive problems with breathing. And the problems associated with nocturnal enuresis bedwetting are, fairly obvious, really. One, it disrupts sleep. So people, you sometimes have to wake up and change the bed halfway through the night so they don't sleep well. There's a significant amount of cost and time spent washing sheets frequently. It's understandably associated with anxiety and depression, and causes a lot of disruption in families. And as people get older, it makes things like school trips and sleepovers and visiting friends much more difficult. So basic measures with nocturnal enuresis are you can use protective sheets to try and obviously stop damaging bed, which is quite an important issue. One issue in sickle cell disease is that people should be taking penicillin, certainly children should still be taking it, and the penicillin it doesn't cause any side effects, but it does make the urine smell quite strongly and quite strange. So often, some of the sickle cell nurses who visit people in their home can tell from the smell in the house, really, when they go in, it smells of penicillin, really, that someone may have a problem with bedwetting. Nappies and pull-ups can be useful, particularly in younger children, and is what normal. Obviously, all children start off in nappies and pull-ups, but there's feeling that they have a limited role, particularly as you get older, and that whilst it solves one of the problems, people can sleep through, and it doesn't, they don't have to change the bedding. It does tend to delay recovery from enuresis, so people just get into the habit of wetting the bed at night. So the general feeling is that after the age of about 7, certainly then that's not a good option, really, and that it may be in certain situations, if you're away or staying in a particular place, then it's a temporary solution, but as a long-term solution, it tends to just prolong the problem, and people tend not to get dry if they wear nappies and pull-ups at an older age. Drinking, I mentioned, really, and the standard advice is to stop drinking water and fluids about an hour before bedtime, which sounds very easy, and to not drink water during the night, but it's actually remarkably difficult. Children, I say children get mixed messages, and adults that they're told to drink a lot during the day, and some parents have encouraged them to drink a lot at night because it seems like the right thing to do. But obviously, if you drink at night, particularly with sickle cell disease, then you produce more wee at night, which makes it very difficult to stay dry. In general, you don't need to drink at night. This is what we tend to tell children. They should drink during the day and sleep at night. And although you still produce some urine during the night, you won't get dehydrated for the 8 or so hours that someone is asleep. If some children who've started drinking at night find it very difficult to stop, and possibly their mouths get dry and they feel they're thirsty, although they're not thirsty in the sense of them being dehydrated. Possibly they can sip water if the mouth is very dry, or you can gradually wean them off water at night, but it's a difficult thing to do. Also, some parents feel that the water at night is important. They're taught from an early age that the children need to drink plenty, and if you'd have to drink plenty during the day, then why shouldn't you drink plenty at night? I think we have to be a bit clearer about that from an early age, exactly what should happen. And that's one of the simplest things that does actually make quite a big difference. If people stop drinking at night, then they wee much less at night, and it's much easier to stay dry. And then constipation. Constipation is a common thing in children. It's maybe more common in sickle cell disease because children sometimes take some painkillers which can cause constipation. And the constipation increases problems with enuresis, as this diagram shows. It's meant to show in the normal situation, the bladder is quite happy, but when your pelvis is full of a kind of feces, then that squashes the bladder and means there's much less room for urine to fill the bladder, and makes it difficult to be dry at night and during the day. So treating constipation, or working out whether someone's constipated, and then treating it with diet and laxatives is a very, very important thing to do. And again, the simple measure, obviously the basic measures are just limiting the damage from enuresis, but in terms of solving it, then stopping children drinking at night and treating constipation solves quite a lot of the problems. Let's make it move on. Obstructive breathing, I mentioned briefly. Some children snore very loudly at night, and their tonsils are big, or their adenoids are big, and it means that the oxygen levels tend to get low because their airways blocked slightly, and they tend to sleep very heavily. And that, when they're so heavily asleep, it's very difficult for them to wake up and pass urine, or for them to stay dry at night. So with the history of obstructive breathing, which really means very loud, all children snore sometimes, but very loud snoring most of the night, often with sort of choking periods where children seem to almost stop breathing because they're snoring so loudly, and that is linked to enuresis. And sometimes children benefit from having overnight oxygen if the oxygen levels are going low, and quite often having an operation to remove the tonsils and adenoids can be useful. And again, doesn't solve the problem in everyone, but again, it's part of the solution. Then waking during the night is in fact what is the solution for many people. And there are various ways of doing this, that given that the urine, more urine is produced in sickle cell disease during the night, then many children, certainly until they're older and the bladder is bigger and more stable, then they need to urinate during the night. And the only way you can do that, or only two ways you can do that, are one, to wet the bed, or to get up and go to the toilet. And the earliest form of that is where the parent wakes the child and takes them to the toilet, so-called lifting. That may mean physically lifting them in smaller children, or waking them up and taking them to the toilet. It's difficult, really, in the sense that it's difficult for the parents. Their sleep is disrupted, and the child has to wake up and go to the toilet. And sometimes, it's hard to get the timing right. Sometimes the parents wake the child too late and they've already wet the bed. But the idea of that is not that that's the long-term solution, but that is one way the child learns to wake themselves up so that they can then pass urine during the night. And the next version of that is to have an enuresis alarm, a bedwetting alarm, which detects wetness and then makes a noise. It's often it clips to the pants or sometimes to a sheet, and it detects small amounts of urine, makes a noise in the child's ear. The child wakes up and goes to wee and avoids, wetting the bed too much. The problems with that are, by definition, you have to weed a bit for it to work. So it's often too late. And often when children start weeing, it's not just a bit, it's sort of the whole bladder empties. And so sometimes the children sleep through the alarm, or it's easy, it's not a very effective way of waking them up. And older children can set alarm for themselves. So they can set alarm at 12 o'clock or 1 o'clock, using their phone or whatever, to wake them up so that they then get up and pass urine. And the end of this journey is really for the child to wake up when the bladder is full and goes to the toilet. Obviously, it's quite a difficult thing to do. You have quite a sophisticated thing to sort of realize when you're asleep that your bladder's full. You wake up, and then you have to get up, and it's often dark and cold, and find the toilet. And sometimes that means going up or downstairs. You have to wee and then go back to bed. But in fact, that pattern, waking up at night, is called nocturia, and that is how most people, it's fairly uncommon. Older adults without sickle cell disease often have to do that. But in children, then that doesn't tend to happen, that most children sleep through. But in sickle cell disease, about 80% of people report that they have nocturia, meaning that they get up at night. So the long-term answer for most people with enuresis is to learn to wake up at night, although and to pass urine. It sounds easy, but it's not that straightforward, particularly getting conditioned to wake up when your bladder's full. And it's not something you can teach someone either. So if their sleeping is disturbed because they're snoring, then that makes it more difficult. And again, it's one reason why younger children, when they're 5 to 10, why they find it difficult. It is difficult waking up at night and in the dark and going to the toilet by yourself. But I think that in the end is probably what many people have to do to stay dry at night with sickle cell disease. It's a picture of enuresis alarm, which is showing the sensor on the pants, and then the alarm actually goes near the child's ears so it wakes him up or her up, and not other people. And then the other option is to try and reduce the amount of urine at night. We've talked about not drinking, which is a practical thing to do, which is quite important to achieve, but not always straightforward. Then there's one drug in particular which can reduce the amount of urine made at night, and this is called desmopressin, which is a synthetic version of the hormone vasopressin that everyone has, that acts on the kidneys. As I said, the kidneys in sickle cell disease are less sensitive, but it can be given either as a tablet or a tablet that melts under the tongue, and it acts on the kidneys to reduce the amount of urine. It doesn't have a miraculous effect, but it reduces the volume by, 10–20%. And that it can be significant if someone's on the point of being dry, if they're almost sleeping through, that can be enough to push them into not being wet. Or if they're having to get up a lot at night, it reduces the amount of urine they produce. And maybe if when they do have enuresis, it reduces the volume of the enuresis. As I said, it's not a miracle and it's not a long-term treatment, but in general, it can act to push people towards becoming dry at night. And typically, people take it for 4 weeks. If there's no response, they stop. If it's helping, they can continue for up to 3 months, potentially longer. But in general, it's not a solution for long term. Bladder instability is the other thing which I mentioned earlier, where the bladder contracts unpredictably, causing enuresis and also causing daytime wetting. And if that seems to be a feature, then there are some drugs which children and adults can take to improve the bladder's stability. It stops it contracting so much. Those are 3 of the drugs: oxybutynin, tolterodine, and imipramine, which are used sometimes like that. Again, that's not generally useful for everyone, but if someone has daytime wetting particularly, or they report, as some children do, that when they have to wee, they have to go urgently to the toilet, they have to rush straight away, and they can't sort of wait till it's the end of a lesson or they're near a toilet, then that is the sort of situation when these drugs can be useful. There are as I said, enuresis is a common problem for children without sickle cell disease, and there are bladder clinics in most hospitals or in most community paediatric services. And our practice in general, if a child's still wet at most nights with sickle cell disease after the age of 7, then we'd refer them to a bladder clinic, and they can take a careful history and understand what's going on and try and work out what the problem is with the enuresis in terms of whether they're drinking too much or whether they've got bladder instability. Sometimes a scan of the bladder can be helpful in that sometimes people urinate, they pass urine, and the bladder doesn't fully empty, so that tends to make people want to urinate more frequently. And they can also give detailed advice about the alarms and drugs that we talked about. Psychology is quite important. Enuresis, although it's very common and people don't tend to talk about it a lot, then it is a very stressful problem. It's difficult for the child and it's stressful for the family and the other brothers and sisters. People tend to blame the child for it. It's very hard not to, even though it's not their fault. Then there's still a tendency to see the child who wets the bed as being lazy or doing it deliberately in some way. And so it's very important that families where this is occurring do get enough support, and particularly support for the individual child, so that they understand what's going on and it doesn't make them depressed or stressed, and also support for the family to try and deal with the enuresis, which is a difficult problem and it's stressful for everyone and it's expensive. It costs a lot to in washing powders and replacing sheets and things like that. There are quite a lot of good patient information resources and leaflets available. There's one called, the one in the UK is called eric.org.uk, which has lots of information and videos and information leaflets. And there is quite a lot of support around. This is not specifically for sickle cell disease, but the issues are in general the same. The thing that's different in sickle cell disease is the fact that a lot of people end up still having nocturia. So the answer is not to sleep through the night, but is to learn to wake up and pass urine during the night. This is a page from the ERIC website, which is just an example where there's lots of sort of quite useful and child-friendly information. And so in summary, enuresis is common in sickle cell disease. In general, if investigation and treatment is probably recommended if it persists after the age of 7 years. It resolves in nearly all children as they learn to wake up and pass urine during the night, but 80% of children and adults report having to get up at night to pass urine. Strangely, that doesn't really matter. It doesn't make you more tired, and people, once you get into the habit, you can break your sleep, get up, wee, go back to sleep, and still have a good night's sleep. And there are certain but definite benefits from not drinking at night and avoiding constipation. Thank you.
Thank you very much, Professor Rees, for this comprehensive presentation. Maybe, Professor Rees, with your permission, I can suggest also to listen indeed your interview performed for the EHA on precision medicine and also hemoglobinopathies. So
Yes.
I will write all the link in the chat. I will just provide them now, but it's nice also to, even if it's not strictly linked to today's topic, but please, this is a great interview. I had the chance to listen to it. So I really encourage the audience to listen to this podcast. I see, Soterula, you want to raise your question? You can, I think, reactivate your, yes.
Hello, thank you for
Hello.
the presentation.
Hello.
My question is not according to the enurésie, but according to the hydration. Until now, we knew everybody that if patient with sickle cell disease has crisis, you have to give IV fluids. But you told now that it's not necessary if they are not dehydrated. Only when they're dehydrated, we have to give intravenously fluids. So what are the new guidelines if a patient will have crisis, vaso-occlusive crisis? Do we have to give fluids intravenously or not?
Well, I think no is the answer. I think it depends where you work, but the guidelines, say in the UK, have said this for a long time and in lots of countries, that I think you need to assess, some people need IV fluids, but it's a mistake to put it in everyone. There's one, as you damage the veins and people end up with no venous access by the time they're 20. And secondly, it's unnecessary and people tend to recover better with oral fluids. So we tend to only use them if someone's vomiting or if they're very febrile or they've, they're severely dehydrated when they come in. I think there's no good evidence on that IV fluids is beneficial. And in fact, there are some studies now coming out showing it's potentially harmful as well, that not just in sickle, but, and again, it depends which fluids you give, whether you give saline or Hartmann's or dextrose, and we just don't know. So in general, if certainly there's no evidence it helps people get better. It's important to not let them get dehydrated. So the same for any adult or child. I think you would assess them whether they need IV fluids or not.
Thank you very much.
I think in very hot countries, it's sometimes a bit different. And I know in the Middle East, people, always give IV fluids. And maybe if it's very hot, then that's sensible. But in London, it's never very hot, so we can manage without.
Okay, thank you.
Thank you very much. So we'll address now one question that has been written in the chat. Thank you for organizing this session, a pleasure. Will you share the slides afterward? Everything will be available. Yes, also the video. Sorry if I missed it. At what age is it considered enurésis? My son is 5 years old, sickle cell disease SS. And what's the bed every night? And all doctors keep telling me there is nothing to do before 6. We live in France.
Well, it's difficult, isn't it? I mean, I think based on the figures, up to half the children with sickle cell disease still wet the bed nearly every night at the age of 5. So our guidelines say 7, really. If someone is still having frequent enuresis at the age of 7, we would refer them. I still think there are things you can still do. I think, as the things I mentioned, like, stopping drinking at night and trying to get the child to wake up at night to pass urine, even at the age of 5, you can still do that. So I don't think it's the case that there's nothing you can do, but I think it's not the case that you need specialist referral or lots of investigations at that age. So I don't know what you do. I think stopping drinking at night and trying to wake your child before they wee the bed is the simple things you can try and do at that age. I think leaving him in or her in nappies is one solution and it solves some problems, but it doesn't help solve the problem overall and is best avoided if possible.
Thank you very much. So now I can see another hand raised, so we'll give you in 1 second the possibility to take the floor. Speaking to Yasser Aid. Okay.
Yes, good evening.
Hello.
Do you hear me?
Yes.
I have a question about the kidneys function and the relation between constipation and kidneys function. Is it can be constipation caused of kidneys dysfunction? I did not understand truly the relation between the two things.
No, not directly. I think it's just a physical thing that if you're constipated, you have lots of feces stored in your pelvis and that squashes the bladder. So it doesn't affect the kidney function, but it means your bladder is quite small and that you can't hold much wee in your bladder. So you tend to go to the toilet more often. Does that make sense? Yeah. So it doesn't affect the kidneys, not directly, not unless you've got really bad, horribly constipated. But a lot of children don't empty their bowels every day, and they have a lot of feces sitting in their pelvis, which squashes the bladder, and then means they have a reduced bladder capacity, so they're more likely to wee the bed.
Thank you. Thank you so much.
Thank you very much. We have another question. I stopped myself. Thank you for your presentation. Does hydroxyurea efficient in énurésie and polyuria?
It's a good question. I think there's no evidence that it does. People looked in a big study called the Baby Hug study. They looked to see whether giving hydroxyurea early could reduce the kidney tendency to make too much urine, and in fact it didn't show that. It was a big study and they gave hydroxyurea and it didn't affect the kidney function. So I think there's lots of reasons for taking hydroxyurea, but as far as we know, it doesn't alter the problem with enuresis, even when it's given early. The idea was that you could stop the kidneys being damaged, which happens at an early age, but that didn't seem to happen. So I think it's still very good to give it, definitely, but there's no evidence it improves enuresis.
Okay, thank you very much. So I'm reading a comment. I think it's so important to make the links with different areas. For example, our sickle cell specialist is not an expert on enuresia and what links there may exist. So bravo for organizing this webinar linking the different areas. Thank you very much. It's really important for us to receive those warming and encouraging words. Thank you a lot. So I think now we are really at the end of our session. So thanks again, all of you, for this great lecture and questions and debate. And I wish to see all of you on the next one on the 5th of December. And so thank you very much to all of you.
Thank you.
Thank you.
Bye-bye.
Bye.